this is part of a series of events, and at the heart of all of these events is us sharing our learning and what we're hearing from the projects that we fund and the people that we meet right here in Lambeth and Southwark, trying to try out new ideas in health innovation. So the things that we're going to talk about today are actually echoing what people have told us and what we have experienced, but we're also really hoping that you'll be able to share your experiences of communicating health innovation with us today, and that we can extend that learning and take it even further. So Kieran's mentioned we'd had some previous events. We've had events on co-production, on sustaining impact and sustaining change in health innovation, and also discussions on health beyond healthcare. And so where do we get these topics from? We don't just pluck them out of the air. We listen to you guys. So Kieran's already given a plug for the feedback form. A lot of the information comes from listening to people who have been from our events, also from meeting people and speaking to them and hearing about some of their challenges. For those of you who are funded by the charity currently and have to fill in any of our interim reports, or indeed have completed a final report, all of that hard work isn't wasted. We do read them all and assess them all and talk about them in detail. And actually, the lessons and the topics that we choose often come from the feedback that we get from those final reports. And that's actually where today's event has come from, the issue around communicating health innovation. So why did we choose that? Why is that something that we've talked about? Well, we've been out and we've been listening to people, and we've heard that sometimes people find this quite a tricky topic. They don't necessarily know how to do it, how to go about it, or they want some tips from others who have done it successfully. And that also people have struggled to understand its place in health innovation, to understand, is it really a core part of what they do? People tell us that actually implementing and delivering new ideas in health is something that's quite hard, and communications can sometimes be left to last, a bit of a bolt-on, a bit of something that they think of at the last minute. But then the flip side of this is the projects who are doing it really well, or the health innovations who've really embraced communications and put it at the heart of what they're doing. And they see it as central to what they're delivering and as a core component of how they're going to deliver change and deliver difference. And therefore we thought there was enough there to have the kind of embryos of an event and a discussion, and to see whether that's something that echoed around the room and whether we could get people to share their experiences as well. But rather than just convene an event and start with a blank sheet of paper, we've been out and about over the last probably 8 weeks, speaking to a number of projects that we fund, a small selection of the hundreds, but a number of them, and asking them about their communications journey, what they had been doing, why they had valued communications or not valued communications, how it could contribute to them achieving their goals, and what we could learn from them, the challenges and the opportunities. And there's probably kind of 2 reflections that I could give around what we've heard. And then what we've done is we've begun to collate some emerging principles that I'm going to attempt to canter through in probably the 6 minutes I have left in speaking with you. And then I'll be introducing the speakers who will talk about their individual projects. And the 2 reflections that we have had is, one, that communications is quite often overlooked, and that it is seen as a bolt-on, as I mentioned earlier, and not necessarily seen as core to delivering health innovation, and that people can be quite nervous about talking about their new idea before it's actually fully grown, that they want to kind of keep it under wraps until they definitely know it's going to work and they've got all the evidence to prove it, and therefore they need to think about how to communicate. So quite often they think about communications perhaps as disseminating the findings at the end, or announcing the project at the beginning, and then the in-between bit, they want to keep it under wraps. And then we've also heard from some great projects who have seen the benefits of good communications and have seen how it really helps to deliver a core component of their project, and really seen it as an essential part. We've even seen kind of varying definitions of communications as we've been out talking to people as well. So ironically, communication seems to have a bit of a PR problem, and people don't necessarily seem to be sure always exactly what it is. But when we've spoken to those projects who have been doing really well. They've given us a definition themselves. They've been talking to us about how, when it's used effectively, it's about a two-way process. It's not about just churning out information into a vacuum. It's about exchanging information, new ideas, and creating a shared understanding, whatever the area of health innovation you might be working in. And I guess the word that kept coming up on those particular areas was around it being a dialogue, a conversation with people about the work that you're trying to achieve. So those were the kind of two reflections that we had as we were out listening to people. And then we began to hone that into 5 emerging principles. And these are the things that we're hoping to debate and test today. And actually, a success for me today would be if we'd kind of torn those 5 principles up at the end of it, had a really good dialogue, and come out with some new ones as well based on your experience. But I will take you through them quickly anyway. So firstly, identify how communications can help reach an innovation's goal. So this is about a reflection that communications should be strategically considered within your health innovation and within your project. That really, to implement communications successfully within your program, you should be thinking about what value it adds to your program and how it contributes for you to reach your goals, rather than thinking about it as an add-on. And for areas that don't crack this properly, it will always be the kind of superficial, fluffy bit, the thing that isn't necessary within a project. So whether your particular area, a goal of your project might be convincing commissioners to adopt a new idea, or engaging with GPs to think about implementing your particular innovation, it's really essential that you think about what that goal is and how communications will contribute to that. And I think when we hear from Anatole, hopefully later, thinking about the SXT project, one of the things, if you can't kind of quite crack that, maybe thinking about getting some specialist support or some advice as well to really understand how communications contributes to the project's success will be vital. Secondly, from a principle point of view that we're going to test around today, is around getting to know your audiences and thinking about their needs. So I had the privilege of looking through the guest attendance list today, and we have a disparate group of people around the room from a variety of organisations here today, which really demonstrates how enormous variety people working and interested in health innovation is. And I am sure for many of the projects that you represent, that is true when you think about your audiences as well. You're not thinking about one group, you're thinking about a number of different people. And you are all coming today with your own experiences and your own reflections on the topic. And when you're communicating with people about what you're trying to do, that is often the same as well. So thinking about your audiences and understanding what their needs are before you begin communication is one of the things that's come out quite strongly as we've talked to people about this topic around Lambeth and Southwark. So learning from them. So I think one example that came up in some of the interviews was around a particular innovation that might have an impact on someone else's service. So when communicating with them, being really acutely aware about their perspective on that and communicating in an appropriate way. So once you've known why you're bothering doing it in the first place, who you're going to do it with, the third principle that's emerging is about finding the best avenues to reach people. So this is where some of the kind of nuggets about where health might present some particular challenges have come out as we've been speaking to people. So I think quite frequently we've heard when people working in health innovation have been looking to work particularly with NHS colleagues, IT and its archaic nature and some of the struggles with IT with some of our NHS counterparts, so might have come up quite frequently. We've also heard quite a bit about the benefits of face-to-face communications and about not underestimating the shoe leather approach, as we sometimes call it, kind of getting out and actually meeting people and talking to them directly about the change that you might want to see. And I think when Carly speaks about the Alchemy Project a bit, she'll be talking about perhaps using other people and champions to be able to do that. And also about existing channels. We're very fortunate here in Lambeth and Southwark that there are lots of existing communication channels to reach, particularly health professionals, but other audiences as well, and the opportunity to use those and utilise those rather than always feeling the need to create another newsletter or create more content.
Okay, so communicating health innovation. SXT is a little project that I set up 5 years ago now with some support from a number of people, and thank you guys in St. Thomas's Charity. But the big problem I was facing as a clinician was that users were frustrated about poor access to services. There were time-sensitive services they were not getting access to appropriately, and of course there were poor health sequelae because of that. And then there was a mismatch between the providers that exist and the capacity that has, and the demand that there are from patients. So you found that mismatch meant that people were queuing up to go to one place when there was somewhere down the road that it could be managed effectively. And the image online was really patchy. It was in the control of IT and communications departments in trusts, and not in the hands of frontline providers, and that's what I really wanted to address. So SXT is a relatively new website. It's provider controlled, so you can communicate what you offer, and it helps people find the right service in the right place at the right time. And communications is something we thought a lot about from the beginning, because nobody was doing anything like this initially. To make it succeed, we had to obviously raise awareness, and you're in a catch-22 when you don't have enough providers in your database to start with. So we had some early adopters, and thanks to all of those, and then we also uploaded from various databases, providers, and we could show it working with SMS, and then we moved to mobile and web, as SMS was less useful in this sort of domain. And convincing people to use the new tool meant that we had to always get data out. So our approach was not only to make a really nice, user-friendly interface website, but we also wanted to make sure that the data came out so we could then report back to people and say, do you know what, this is working. You can look on an analytics page and see people using the platform to find your service. And it was only latterly that I got some specialist support, but I found that really useful way of approaching the sort of the communications journey in an alternative fashion, by speaking to people before things were launched, as opposed to launching things, measuring them, and then evaluating them. And this is the website. I put a card on everyone's table, so if you want to check out the website, please do. If you know anyone who needs a service, then this is the place to go. And we just upgraded in June this year, and we've had 6,000 users since the end of June, which is fantastic, with great detail about who's using services. And when people choose a provider, 16% are giving feedback, and we've got a net promoter score of 8.8 out of 10, so we're having about 80% of users giving us a score of 8 or more out of 10 when they find a service. There's many audiences that we had to talk to. We had to talk to providers and encourage them to think about it. We had to talk to commissioners. We had to talk to members of the profession, obviously. And then the most important thing is talking to clients, finding out what they want. And they want something that works quickly. They want something that just delivers, and as quickly as possible. So it gives information in under a minute about what is available locally. And we use different ways of trying to get people to use the website. And still, I'm finding the hardest thing is getting websites to feel confident about posting a link up there. So I've just got a new emergency contraception calculator that I think is going to be my hook into various clinics, to get an icon and a link to the platform. But that's one of the big challenges. But we use paper, we've used ad tags, we've used Google Ads, and many other ways. But it's important to make sure that you communicate in a way that people understand. So just to give two diverse examples, on your left is some stills from an animation, Tom Meets SXT, which is a sort of raunchy 2-minute YouTube animation about partner notification for men who have sex with men. And the third image with the red face is the difficulty people have about telling partners, for example. On the right is a dashboard that I'm working with the company Alaron. We're communicating out what's happening on the website in real time and sending that back to providers so they can see who's using the website, why they're using the website, and the sort of traffic that is happening on SXT. So we use many different ways of communicating, and of course, as the data starts flowing, it makes it possible to start presenting at conferences and invited to write articles, etc. And that's a really helpful way of speaking to the profession. but it's very difficult sometimes to measure what is working. And with things like Google Ads, you can see a conversion rate and you can see people coming on the site. But when you're giving out cards or you have posters, or it's difficult to actually convert that activity into real use of the site. So we've been, since the very beginning, really reflecting on exactly what works the best. Guys and St Thomas's Trust gave a small grant to SXT to put ad tags up everywhere, which are 2D barcodes and near-field communication. As an early adopter, I put these up all over Lambeth and Southwark, and hardly anyone started using them, even though I had some really great early data. So it's easy to obviously get there too early or try things that don't work. But capturing the feedback is key, and of course I told you about the Net Promoter Score, and we do that for every single service that we're delivering. And it's just nice to try new things and see what works. And the new thing is Bluetooth beacons. I'm not sure if they're going to work out, but it might be nice to try that if anyone wants to do a project. But finding the right voice is difficult, especially when you're early on and people don't really know what you're going to be in 4 or 5 years' time. There's a sense of, do I take a punt with this person or not? And when I got a grant recently from the Cabinet Office to develop the emergency contraception calculator, Alaron said, well, why don't you start speaking with the commissioners first and GPs and others before you've actually finished it? So that was a completely new thing for me, to actually start talking about something before we delivered the baby, so to speak. And it was a good approach. I learned a lot thinking that way, and of course now it's gone live. We're starting to disseminate it. And finding key messages is key, and it's all about looking at the data that you collect. So one of the big things that SXT has developed, and it went live at the end of January, and I'm just going to sort of speak to this because this is changing how the profession is delivering service. It's very hard when you find someone with a new infection to get their partners told. We know at least a third of partners will have the infection diagnosed in the person in the clinic, and that's true for all STIs. This is a challenging area. It's always been the hardest problem to solve in sexual health. So SXT, because it helps people find services, we thought, well, why can't we help partners find services once we know someone has an infection? So it works in the clinic, it works on the bus on the way home for the person with the infection, who's called the index patient. And then when the partners turn up to any clinic across the UK, they get an optimal service. And it's a text message that we send out, and it's an anonymous platform, and then they click on the link and it opens up a web page that tells them what to do, and it gives instructions to the clinic on what they should do with this person, and it gives instructions to the clinician on how to unlock this unique code and find out what that person's been exposed to. And this is a really impressive piece of communicating in a way, because we're talking to people who've never even contemplated going to a sexual health clinic, so it's actually, we're really breaking new ground, and it's not an easy message to send to anyone who is a partner. But it's also very difficult to communicate all the volume of data back to clinicians. We've done this for many years, but it's actually hard getting the data out and showing that it's effective. So we created a Bullseye figure to actually talk about partner notification. So we've had 1,313 index patients, that's people with STIs, using this platform. And the grey circle represents the total number of partners they declared in clinic. The maroon is the number that they can contact. The light blue is how many they've actually told with the platform. The dark blue is how many they actually told open the link to actually find out about what they've been exposed to. And then the bullseye, the pink, is how many of those partners actually turned up and were verified as seen in a clinic. And this way of communicating is never been done before for partner notification, but hitting the bullseye is exactly what we're trying to do, and that's the public health story that we need to tell. And it's different for different STIs. So HIV is different to syphilis, is different to trichomonas vaginalis, and trichomonas vaginalis is seen mostly in the heterosexual black community, while syphilis is mostly in men who have sex with men. And I've got a poster at the STD Prevention Conference in Atlanta talking about and also Public Health England next week, talking about how these different diseases sort of unravel how different groups communicate with each other to try and deal with these epidemics. So the top lessons are that you need to really think from the very beginning about what you're doing, and especially if you're doing something brand new that nobody knows about, and sort of holding the hand of people around you and saying, this the vision and this is what we're trying to achieve. It's really difficult at the beginning when you don't have data, but the key is to get as much data as early as possible. And then keep on talking to people, keep on iterating. Everything that's been built has been built with providers, with clients, just to make sure that it works for them. And then when it comes to getting people to know about the site, it's using different tools to try and do that. And some work better than others, and some work, but you just don't see that for many weeks or months later. And then, assessing it all the time. So in the back end of SXT, there's really strong analytics, but we're using Google Analytics as well and other platforms to see how it's working. And then telling the story before you finished is something I'm getting used to because I can now see that it's actually adding value, and the plan is to obviously scale up as much as possible and keep on telling a story with really good data.
As we heard, like psychosis is a major health problem. And is particularly high in South London. And what we've seen is that early intervention has proved to be really effective in promoting mental health recovery, engagement, and avoiding that social exclusion, isolation, and motivation. So in my work as a dance director, I've seen time and time again the power of dance in improving health and well-being. So whilst working with Dance United Yorkshire and building on the success of the pilot in 2013, we created the Alchemy Project, which you saw is a pioneering intervention that helps young adults recover from psychosis through dance. The action research was a co-production between Cultural and Utilities and Enterprises in association with Dance United Yorkshire and South London and Maudsley NHS Foundation Trust. The Alchemy Project involved delivering intensive 4-week dance-led interventions to young adults who were accessing the early intervention in psychosis services at SLAM. And the research that we've seen has that it's a powerful catalyst for the recovery of those service users. And distinctiveness is around the intensity of the work. So for us, winning the hearts and minds through communication was essential. So the Alchemy Project takes contemporary dance into completely uncharted territory of a frontline mental health service. It involves a way of working that is radically different from, yet complements the work that is already existing in that service. So making the Alchemy Project a success relied on getting buy-in from senior clinicians, getting the frontline teams in SLAM to really embrace the project, and winning the support of commissioners. So good communication has been critical to achieving all of this. From the outset of the project, we knew we needed to use communication to open new conversations about how to embed the Alchemy Project and get it commissioned. We knew that many people in healthcare are wary or perhaps sceptical of arts-based interventions. They often don't understand their value and impact and see them as nice to have. We had planned an evaluation to evidence impact, but we knew that we also needed something that would immerse people in the young adult's journey through the intervention. And the rigour of the process in the way that written word and an evaluation report could not. So the power of film. We had previously used short films to help raise the profile of our work and thought film was a way to go. Yet we knew a 5-minute film wasn't going to provide real insights into the project to win those hearts and minds and open up new conversations. We needed to help sustain the Alchemy Project. So from the outset, we planned to produce a long-form documentary. So you just saw a 5-minute trailer from a longer documentary. We engaged professional filmmakers to help us with the film. We included the voice of young people, as well as clinicians talking about their experiences and the impact of the project has for the system as well as their practice. We also featured national and local commentators to set the work in a wider context. Using different voices, I think, brought authenticity, and it allowed the film to speak effectively to varied audiences and connect with their specific interests and motivations. To protect the young adults featured, we had very strict agreements with SLAM. The film could not be broadcast widely, so we adopted a highly targeted approach to screenings. And this gave us some intimacy of these events and has made the screenings, I think, more powerful, and it's made it easier for us to continue the dialogue afterwards. We've shown the film in different contexts, sometimes in one-to-one meetings, other times in small or large groups, and this has presented opportunities that we would probably never have had. For example, earlier this year, we screened at the inquiry of the All Parliamentary Group, which is exploring arts and health. And a social investor at that meeting approached us to explore, could this project work in Oxford, which he was based, and of course it could. And this is still very much work in progress, but an opportunity and contact that may not have come about if we hadn't have had a powerful film. The 40-minute documentary has been really effective in winning hearts and minds. What we hadn't taken into account at the beginning of the project is that some of the audiences we wanted to communicate with were reluctant to sit through a 40-minute documentary due to time constraints, and that's where we responded by creating a short trailer to whet the appetites and to engage them in watching the full documentary. The trailer has meant that we've been able to give a taster of the Alchemy Project in more settings, for example, existing meetings, and we've learned from that and we'll apply it in the future. The film has become a really powerful asset for Alchemy, and it's helped us change the tone of conversations with commissioners and helped us to explore some of the hurdles in overcoming that. Nurturing champions has been really powerful and has been a really distinctive feature of the Alchemy Project. So we've helped work with senior clinicians as well as frontline staff to help them become communication channels for the project and come on board. So one of our champions has opened up some exciting and innovative approaches in terms of writing opinion pieces. So there's a blog that is on the Royal Society of Psychiatrists website, and that's enabled us to get really peer-to-peer approach, has been really hugely powerful and crediting and credibility and insight into the project. We also have an exhibition of photos through Slam Arts Strategy. So that's positioned in Maudsley Corridor, which is in such a profiled space where you see clinicians, families, carers coming through on a daily basis. So that's given us much more exposure. And then lastly, being part of the bigger conversation, we've aligned ourselves to at the charity here, the Arts Strategy Sustainability Project, and looking at kind of how you be part of those. I guess we were in some ways, because of our film and our assets and our evaluation, we could be classed as the kind of poster girl for that particular work, but I think because we had those assets, it enabled us to align to those to that piece of work, and also to further that conversation of arts and health, and helps our own model as well. So, driving sustainability, we are still trying to we're on that journey with Alchemy to make it sustainable, but I think we're in a much better place because of the way we've used communications throughout our project. Our communication assets, including the film, has certainly opened doors, which we may have not been able to open otherwise. So my top tips for you are understand what you need to achieve, so changing the conversation and winning hearts and minds. So I love face-to-face communication in a really busy, overstretched system. I think that is such a powerful thing to, we heard it earlier, walk in on your lever to kind of build those relationships. Creating the powerful content with powerful messages. So we have both robust data, people love that hard data of graphs, but we also have lots of other tools. And our champions are critical to that, so equipping them with all those different assets, but giving them freedom to communicate their story. and then seize the opportunities to align with the bigger pictures, whether that's for us working with the all-party parliamentary group or the Art Strategy Sustainability Project at Guy's. Thank you.
I've got some lessons around how people communicate innovation that I will talk about very quickly, and then I've got a very quick example of some stuff that we did with the Vanguard in South Somerset, which Gail just mentioned. So I actually spent the first 8 years of my life in healthcare buried away as a data analyst at the top of a tower in North London, and didn't really understand the communications world. We had a communications department. I gave them stuff and it kind of got out there and stuff. And then I kind of stumbled into communications about 8 years ago when I became interested in the fact that the medical profession in particular had lots and lots of information about what was going on in our hospitals, and in the main this wasn't being shared with patients and the public, and I became interested in how we might share complicated data with patients and the public and move action. So was involved in initiatives like how do you publish very complex things like risk-adjusted mortality rates in a way that patients and the public might understand them, but doesn't in fact create fear. And I stumbled along and have eventually ended up at ZPB. Nice to see some friends in the room. We're a consultancy, as Gail says, that helps lots of organisations have a conversation with the NHS. That started off being private sector organisations, but it's now, we work with public sector organisations in a room as well. And it's all about, as I said, having conversations with the NHS. That could be very transactional conversations. Lots of people we work with just want to sell more of their products, and we help them do that. And there's some lessons around there. And I know a lot of the innovators in the room is about developing some kind of product or services that you might want to, in the lowest common denominator, sell into NHS organisations. And there's ways I'll talk about doing that. But also a lot of it, it's about how do you change the conversation. How do you have an NHS, which is constrained by the fact that they haven't got any money and that waiting times are going through the roof and that finances are a problem? How do you have these kind of longer-term transformation conversations that everyone says we need to have, but also, in my experience, aren't going on? So we can talk about a bit more of that in the Q&A, and I'll come on to that in an example. But I've just got kind of a few lessons that I was going to talk about, which I think builds on Gail's principles. And the first thing I'd say is that this is the time to do it. We are absolutely in the information age. There's 1,000 different channels. There's 1,000 different ways. I love technology. As people that know me, I think technology is the key to how we're going to fix the problems in the NHS, but it's also the key to communicating. 10 years ago, we had almost none of these channels, and there was only really 2 ways to communicate, and they were really badged as news and PR. And the old adage was news was information you didn't want people to know, and PR was information you were desperate for people to know. And the trick for people like me 10, 12 years ago was to get a PR story and try and turn it into news. And that was how you communicated to people. You had national newspapers, you had local newspapers. That was pretty much it. So absolutely embrace every channel you can. And as Gail said, it's about thinking about your audience, and I'll come a bit more onto that. Secondly, think about what you're communicating. Very much this is the niche and the space in which ZPB works, but have some data, have some information, have something to communicate. The graph that's still there, as you said, it's not the be-all and end-all, but it's fantastic that you can actually show that well-being scores improved. So at the outset, if you think you're going to do a communication plan, think about collecting data and think about what you want to collect. We ran, for example, a communications campaign a few years ago for a very big, very boring outsourcer who wanted to change the narrative in the way in which they delivered services. So they were being paid quite happily, could have continued on process measures by the hospitals. So they were paid if they changed the beds 3 times a day and washed the sheets and all that kind of thing. What they wanted to be paid about was outcomes, so whether the people that they were looking after were getting hospital-acquired infection, which, as many of you will remember, was rife at the time. So we ran a whole communications campaign where we looked at every hospital in the country, we looked at how much they were paying for their cleaning services, and we were looking at how good their outcomes were. And what we found, and actually some of our clients were in the wrong bracket but could renegotiate their contract, was some of the people paying the highest amount of money had the worst outcomes, and some of the people paying the lowest amount of money had the best outcomes. So it was about putting together a campaign that was evidence-based, which changed the conversation. So I think definitely think about what you're going to communicate. Thirdly, exactly as Gail said, it's about thinking about the messaging. A lot of the work we do, we like to communicate in a way that patients and the public could understand it if they got hold of the campaign, even if it's aimed at what we call B2B. So that would be even if it's kind of professionals talking to NHS clinicians. But we don't want to close shop, so do communicate in a way in which patients can understand it. I saw it, a slight aside, but there was a brilliant thing where I saw NHS England was tendering for a supplier to build the NHS as a social movement, which seemed to me absolutely counterintuitively, because social movements are something that obviously should be ground up and lived. But I don't think we're ever at a point yet where patients are going to demand a product, but if patients understand what you're doing, if they can talk to their GP about it, it's going to have recognition. So, we want a situation where people are saying to their GP practices, it is unacceptable that I have to hang on the phone at an 0845 number for 30 minutes to get an appointment. Why can't I book my appointment online? And if you can explain those messages, it will kind of absolutely help. And also, in terms of messaging and audience, it's about being different. A chair of ASCCG not too far from me told me about this time last year he was getting 30 emails a week into his inbox which was saying, buy my product X and you can meet your commitments in the 5-year forward view. And he showed me them, and every kind of subject line was, innovation in healthcare. Strapline is, the NHS is financially challenged. Please buy my product, you'll meet all your requirements. And that was everything from kind of a new way to do GP rostering to kind of technologies, online booking, etc. So think about your message, think about doing it differently. As one of the colleagues said earlier, face-to-face is as important as kind of just spamming people's inbox. Start to think about, what's the channel? If you're talking to young people, it's about Snapchat, it's about WhatsApp, etc., etc., etc. I find it brilliant that two things I find brilliant that the NHS is doing on communication. First of all, we're just starting to use SMS messaging now, when most phone companies are about to turn SMS messaging off. Suddenly everyone's panicking. Suddenly everyone's saying SMS messaging is safe. I hate to think what would happen if we said to a Caldecott Guardian, can we use WhatsApp please to tell someone the time of their clinic and stuff. But think about channels. I always do this when I talk in this area. Put your hand up if you've had your mobile phone number longer than you've had your address. So I think that's pretty much everyone in the room. Yet the NHS's default position is post. That is the only thing, Dean, that we're allowed to kind of communicate with. And every other channel, there's a bit of a risk. And someone explained it, I was puzzled by this, someone explained it to me. It's because in 1948, when the NHS was founded, there was only one way of communicating, and that was post. And no one said to Bevan, can you get, the government's can you get the Fiona Caldecott of the time to kind of tell us post is safe? Now, I don't know, I think it's very hard to send an SMS message to the wrong number, but mail goes all the time. So we have to have these kind of communications with the people we work with to say we've got to communicate with the best channel and we've got to kind of do the safety. I've had the 2-minute warning, so I'm going to just quickly wrap up, and I won't do my slides, but I can come back to another thing. I think the fourth one I'd say is absolutely kind of be fearless, be prepared to get your message out there. The kind of tech SMEs we work with almost always ask me the same question. They say, I'm really worried, I've got a meeting with a clinical director, but we haven't yet got a randomised control trial. We can't prove what we do is effective in the way that it has with a medication. So should we go and have that conversation? Not dissing randomised control trials and academic research, but I think the dialogue is changing. There's Patients Like Me, which is a website in America, which some of you might have seen, have proved that collecting data from patients absolutely correlates with randomised control trials in the idea of side effects of drugs. So they would ask patients to report on drugs. They would find out that a drug for, say, asthma or whatever also were making people drowsy. And the weight of the patient voice said, we're pretty sure the side effect of this drug is drowsy. 18 months later, the randomised control trial came out and said, this drug makes people drowsy. So don't be afraid of communicating. If you've got the data I mentioned, get out and communicate it. Academic research, as I said, is often important as well, but if you can make some nice graphs like this, infographics, etc., are even better. don't kind of think, I'm going to launch my project, I'm going to stay quiet for 2 years, then I'm going to communicate the kind of evaluated results. Do it all the time and start your conversations. And the example I was going to show was the work we did in the Vanguard with Yeovil, where they said, I think everyone knows the Vanguard, so 5-year forward view came out about nearly 2 years ago now. The Vanguards were putting lots of money to kind of be the exemplars, the trailblazers, and then, you know, everyone from The Guardian to kind of people in Skipton House down the road were ringing them up and saying, well, what have you achieved? How have you spent the $500,000 we gave you? And the campaign we ran with Yeovil was a public-facing dialogue through a series of blogs and websites to be able to show everyone from the national press to NHS England what they wanted to do and how they were starting to achieve without having to wait for kind of the absolutely crystal evidence-based data that was going to take us 2 years to collect. So have a conversation, keep your message, look at the stuff GDS, the government website, have been doing. They're the experts in this, communicating all the time. And then finally, you're not on your own, seek help. So the great thing for innovators, I'm going to put my friend Tara on the spot here, but we have organisations like Academic Health Science Networks who are all over England who have specific skills around helping innovators get their message right and get it communicated. Go and talk to your local AHSN, they'll help. There's lots of organisations like myself. One of the best things about, I think, working about with Guys and Tommy's charity, and they've funded a project for us last year and hopefully going to do one next year, is you've got people like Gail and the team who will give you advice as well as just kind of giving you a load of cash and then walking off. Talk to other organisations, come to events like this and seek help to do it. But I think really my message is, Gail said right at the beginning, communications is either an add-on or there's a bit of fear about it. Don't be afraid at all, and don't make it an add-on, make it absolutely central to your project, because that's how you'll get your innovation to spread.
I think the main thing was delivering on a few other earlier projects that had worked, and then having confidence then in the developer's timeline to actually build what we were going to build. Now, there's always delays when you involve IT in developing new things, but it was really experience of knowing that you could deliver, and then it made it easier to say, yeah, it's going to happen. Of course, it's still nervous when you get to the launch stage and you hope it is going to work, and there's always fine tweaks you have to do, but that was really the main thing.
Well, we had this success as a pilot back in 2013, but last year doing the action research, we wanted to prove if it worked again in terms of getting the same results, but I think our approach has been really to involve people and to really collaborate with others, so to involve them in part of that, in that journey. I think for us, commissioners, in terms of approaching them, came much later once we had the asset like the film and some of the interim findings from the action research. But in terms of involving lots of clinicians right from the beginning, they've been the kind of doors of unlocking things.
So most of what I'm going to talk about is collecting online methods, and obviously I do acknowledge that not everyone is online at the moment, but if you look at the Ofcom data, it's becoming more and more prevalent, and actually some amazing, so 83% of households in this country now have broadband access. I'll give you an example of a project we did with a US company that was it was a maternity company, so it was about helping expectant mothers to take control of their own information, have much better conversations with midwives. And if you look at the Ofcom data on that, something like 96% of women between 18 and 45 now are online, and the 4% that aren't, it's almost always a personal choice not to be online. It's almost always not an economic reason. So in that particular example, we ran some campaigns to help midwives best use the time they had available with mothers. And that was about giving them an app in which they could kind of log all their different conversations that they had. I'll come back to the RCTs in a minute. All their different conversations, all the kind of the thoughts they had. So you could wake up in the middle of the night, you could say, this is the thing I'm really worried about, log it. When you went to see your midwife, she would then say, well, I've looked at your app and here's the 3 things you want to know, and that's how we'll use the 20 minutes and stuff. And when they analysed all the worries that people had, it was nothing to do with what the kind of research said people use the time to talk to their midwives about. So it was about very easy collecting information, and then suddenly it totally, this was a trust in up in near Blackburn, and it rewrote all their patient information leaflets because they realised all the worries were not about, all the kind of research said, Gail, you might want to come in on this, but all the research said people were worried about the biology of childbirth. Will it hurt? How long will I be in labour for? Should I take the drugs, etc., etc. And actually what these people wanted to have was a much more socio-economic conversation with their midwives about, everything to when shall I go and buy the equipment to how will I know if I can afford it, etc., etc., etc. So that's just one example that came to mind, and that was totally through. The brilliance I liked about that is, as I said, people could be awake at night, log it, and suddenly the midwife got the information rather than kind of getting kind of paper surveys or something like that.
So right from the beginning, we knew we wanted to have the voice of the young people. So we really embedded filmmakers into that process. So to build the trust in terms of getting the particular stories, we were incredibly honest with the group at the beginning in terms of why we wanted to make the film, which is we wanted to profile the work with commissioners. We wanted to get the project funded and to have more access for other people to have the project. We also, I think, in terms of building up a whole lot of champions and relationships as we were developing the project, they became commentators into that process. So they'd also been on a journey with us. The filmmakers, I think in all of our work, we work to such a high quality. So in terms of having the filmmakers, they needed to be high quality and sensitive to the kind of process. We knew the message that we wanted to get, which was we wanted to give real insight into the journey, because being inside a dance studio for four weeks is quite a private thing. We don't want to have lots of visitors. When we have the young adults perform on stage, people can't see, well, what was the journey that they got there? So we needed to show that. But we also wanted to show the wider context from clinicians and other commentators about the impact of psychosis and the experiences. So I think we had, I guess, running through threads or headlines right from the beginning and as the film developed that we needed to kind of hit, because we knew that we wanted to show it to lots of different audiences and it had to reach them in lots of different ways. Yeah, so 40 minutes was why we created that long documentary, to reach all of those threads. I think and it's drawing on from our past experience, we could in a 5-minute film show the kind of hearts and minds stuff, but you couldn't really hammer home the impact and value of arts on people with psychosis. Yeah. I'll use an example. We had a senior registrar psychiatrist embedded into the project, so she used her special interest day to see the project firsthand. And she came on board with lots of ideas about writing the opinion piece, but also really advocating and championing the project from inside. I think it's also letting them have ownership of it, but also keeping oversight as well. So we would look at things together, or they'd suggest ideas, and I think that's what's quite interesting, to see where they can take things and have a really powerful message, particularly with their peers, that we couldn't have, and also to give an insight into the project that we would probably never write in the same way about or talk in the same way.